I want to introduce my proposal with the title, Effects of High-Intensity Inspiratory Muscle Training in Patients with Heart Failure with Mildly Reduced and Preserved Ejection Fraction, a randomized controlled trial. Heart failure with mildly reduced and preserved ejection fraction were accounted for over 50% of overall heart failure and associated with high mortality. Inspiratory muscle weakness is one of the complications in heart failure, which makes exercise intolerance, dyspnea, poor functional capacity, and quality of life. Inspiratory muscle weakness was prevalent 30 to 40% in heart failure with preserved ejection fraction. Inspiratory muscle training, or IMT, is an approach to strengthen inspiratory muscle. By that way, improve and reduce above symptoms. Inspiratory muscle weakness is defined as maximal inspiratory pressure, or MIP, less than 70% of predicted value. To evaluate the MIP, patients will be instructed to inhale forcefully through a spirometer. Until now, 2 trials were performed to evaluate the efficacy of IMT in heart failure with preserved ejection fraction. But most studies use low to moderate intensity IMT. In addition, they use unblinded trial, small sample size, and lack of report of the compliance to home-based IMT program. An interesting finding is no previous study evaluated effects of IMT in heart failure with mildly reduced ejection fraction. So, the gap of knowledge is that there have been no study performed to evaluate the effects of high-intensity IMT on patients with heart failure with mildly reduced and preserved ejection fraction. Based on current evidence, the questions are, firstly, does the home-based high-intensity IMT program increase VO2 peak from the baseline more than that in sham control in patients with heart failure with mildly reduced and preserved ejection fraction? The second question is, does the home-based high-intensity IMT program improve MIP, 6-minute walking distance, quality of life, and echocardiographic diastolic parameters? We use randomized controlled trial design with 2 groups, high-intensity IMT and sham IMT. The inclusion and exclusion criteria are as presented in this slide. We use block randomization method, and cardiologists, physiotherapists, researchers are blinded to the patient's allocation group, and participants are blinded to one other intervention. The intervention protocol, high-intensity IMT will be warmed up in 5 minutes. Training resistance will be set at 30% MIP in the first week, 50% MIP in the second week, and 70% MIP from the third week. The cooldown will be performed in 5 minutes. The sham IMT will be warm up and cool down similar to high-intensity IMT. The training resistance will be kept at 15% of MIP. The primary endpoint is the change in VO2 peak at 8 weeks. The secondary endpoints are maximal inspiratory pressure, 6-minute walking distance, quality of life, and diastolic function. The compliance will be managed by a logbook, telemonitoring by Zoom online, and the checklist. The statistical analysis, intention to treat, and analysis will be considered. Limitations. Some problems with compliance could arise, but we use telemonitoring and diary to alleviate the limitations. Thank you very much for your attention.